Hello and good day to everyone. It's good to be back once again, and I am very pleased to have another special guest and top fertility expert with us tonight. As you can see, this is Dr. Seang Lin Tan. It's good to have you here with us. So thank you so much for joining our Stronger Together initiative, and thank you for presenting tonight as well. And how are you feeling tonight?
Oh, thank you very much, Caroline, and thank you and Jacob for inviting me to speak. Okay.
We are definitely excited and very, very pleased that you agreed to be part of our Strong Get Together. So huge thanks for that as well. And before we start with your presentation tonight, let me just mention that, of course, as you know, we are here every single day as we want to give you this opportunity to meet top fertility experts to answer your questions, but of course to support you. This has been a very strange year for all of us, and we are just hoping that we were able to help you, even if a little. And as you know, this is our actual final event tonight. So when it comes to Stronger Together this year, because we will be back, we don't know yet that we don't have the dates yet, but of course you will be updated. We will be back here next year with some more of those events, as we definitely want to keep on supporting you. And that's why I would like to thank everyone here for joining us over and over again. I know some of you already had a chance to be here for our previous webinars as well. So huge thanks for that. And I also want to thank our ambassadors and partners. They have been with us from the very beginning when we started all those events in March. So thanks a lot for supporting this initiative and being part of this team as well. Thank you so much indeed. And well, now I would love to show you that we do have another special guest, as I mentioned, Dr. Seang Lin Tan. And as you can see, he's a professor of obstetrics and gynecology at McGill University, but he's also the medical director at OriginElle Fertility Clinic, which is of course located in Montreal in Canada. And he is also founding director of McGill Reproductive Centre. So we are very pleased that you have found some time and will be presenting a very interesting topic on modified natural, early trigger modified natural cycle, IVF and IVM as an attractive option for poor responders. So thank you so much for bringing this topic. And well, Dr. Tan, are you ready to begin?
Thank you, Caroline.
Thank you so
So
much.
I was asked to speak as part of your series on the treatment of patients who have failed IVF. Okay, and so this is the slide in front of you was the hospital in McGill University Health Center that I was the director of for 16 years from 1994 to 2010. My journey into the fertility world, and more specifically into this topic of in vitro maturation of oocytes, started off more than 2 decades ago when I was working in England with Professor Stuart Campbell, who was one of the pioneers of ultrasound in obstetrics and gynecology, with Professor Howard Jacobs, who was the person who first described polycystic ovarian syndrome and polycystic ovaries in the early 1980s in the landmark paper in the Lancet, and of course Professor Robert Edwards, the inventor of IVF and the Nobel laureate of medicine in 2010 for being the first person in the world to do in vitro fertilization. So the four of us were partners, and we ran this clinic in London called the London Women's Clinic, which is the junction of Harley Street and Cavendish Street, which is a very famous clinic in London which still exists today. And I remember at that time when I was a young doctor, that Professor Edwards told me, he said that although he is widely credited of being the pioneer of IVF, in fact, before that, his first love was IVM. And the reason was because he said that although today fertility doctors give women hormone medications around the world for in vitro fertilization, as far as he was concerned, most women would have preferred not to have hormonal injections every day if they could. Because which woman would like to give themselves expensive hormones, which cost money, may have side effects unless they really have to. So he always had a first love of doing in vitro fertilization without the need for drugs. So he was the inspiration for my work in this field of in vitro maturation of oocytes, or IVM. Now, IVM just means collecting eggs from the ovaries before all the eggs are mature, and then maturing the eggs in the laboratory. So in vitro means in the laboratory. So in vitro fertilization means fertilization of the eggs outside the body. In vitro maturation means maturing the eggs outside the body. Okay, that's all it means. Okay, so typically in IVF, we give the patient medications, or we don't give any medications, and we wait until the biggest follicles in the ovary containing the eggs are at a stage when the eggs are mature. Typically when the follicles are 18, 19, or 20 millimeters in diameter. By that time, if no drugs have been given, there's usually only one follicle in the ovary. On the other hand, if we were to collect the eggs when the follicles are 10, 12, 14 millimeters in diameter, some eggs will be mature, but most of the eggs will not be mature. And IVM refers to the maturing of these immature eggs in the laboratory. So how does it work for patients with poor responders or poor quality embryos? That's the topic of this lecture. So as we know, a proportion of women undergoing IVF treatment do not respond well to medications. Obviously, if they are in their 40s and early menopausal, we may not expect them to respond to medications. But sometimes even young women who are in their 30s, mid-30s, early 30s, or late 30s, even if they have a normal ovarian reserve, for some reason or other, they do not respond to medication. And despite giving more and more doses of medication, now here there's a difference of practice in different countries. In Europe, most doctors stop at 300 or 450 international units of medication per day. In North America, both in Canada and the United States, the dose of medication can be as high as 600 international units per day. In a few countries, like in Israel, some doctors might even go as high as 1,200 IU a day. But whatever the dose is, okay, once you go to very big doses, you expect some sort of response. If, however, a patient has tried different stimulation protocols, antagonist protocol, long protocol, microdose flare protocol, with different medications, Gonal F, Purigon, Menopur, whatever, and there are very few follicles developing, they're called poor responders. And depending on the age of the patient, the percentage of poor responders can be small or can be a quite large one. Now, obviously, women who are older, advanced maternal age, or who are low ovarian reserve would be expected to have poor response. The second topic for this lecture is young patients who, for no obvious reason, produce poor quality embryos repeatedly. So again here, I'm not referring to a 43-year-old woman who may have 4 embryos and 2 or 3 of which are not good quality. That is to be expected, okay, in many places. However, if you have a young patient in her 30s and who produces 8 embryos and 7 of them are bad quality, then it's unusual. If you have ruled out a sperm factor like a DNA fragmentation being responsible or a laboratory issue, then we have to think maybe it is the way we give medication that is the problem. In fact, I started performing IVM in Montreal because of this reason. My very first patient having IVM was a young Middle Eastern doctor who was at McGill University for training, okay? She tried 3 in vitro fertilization cycles for blocked fallopian tubes, and despite using different stimulation protocols, almost all the embryos were poor quality, okay? And she didn't become pregnant. I had suggested to her performing egg donation, but because she was a very religious Sunni Muslim, she could not do egg donation, and she opted to try in vitro maturation of eggs. In the very first cycle, we collected for her a number of eggs, produced a number of embryos, and unexpectedly, all the embryos were good quality. We put in for her 2 embryos and she had a baby. She went back to the Middle East. A few years later, she wanted a second child. She tried in vitro fertilization again in Europe and in the Middle East several times, not any success. So she flew back to Canada to see me. We did for her IVM again, and she had a baby a second time. So inspired by her case, okay, we tried the same method of using in vitro maturation of eggs in the number of women who have had unexpectedly poor quality embryos. And to our surprise, some of them end up having good quality embryos. I do not know the reason why, except that I think fertility drugs that we give may not be suitable for every patient that we have. That's all. So in these cases, the so-called modified natural cycle IVF, IVM can be used. As I mentioned, IVM is maturing immature eggs in culture after they have been collected from very small follicles in the ovary. The reasons why we do IVM are as follows. The most common reason many years ago was in women with polycystic ovaries or polycystic ovarian syndrome and who were at very high risk of developing ovarian hyperstimulation syndrome. Now today, as you know, OHSS that's severe is very uncommon because modern stimulation protocols using the antagonist protocol with the agonist trigger using Lupron or buserelin has led to almost virtually no severe OHSS. Having said this, there are still some case reports that unexpectedly some women, despite all the methods of stimulation, do develop OHSS. And the only guaranteed way of not getting OHSS is not to have large doses of fertility drugs. So patients with poor responders or unexpected poor embryo quality, again, is for a reason for IVM. The next topic, which I won't have time to discuss today, is using IVM as the first line of treatment instead of doing artificial insemination. The reason for this is simply in 2 sentences. With artificial insemination using gonadotropin injections, one needs to have anywhere from 6 to 10 injections of hormones starting on the 3rd day of the menstrual cycle. And the success rate of getting pregnant is like a 10, 15, maximum 20%. And the cost of treatment, once you include the cost of medication, is $2,000 or $3,000. And there is a risk of multiple birth. On the other hand, with IVM, we can give less drugs, collect a number of immature eggs, mature them in the laboratory, and transfer in 1 or 2 embryos. The pregnancy rate is twice that of IUI, 40%. The cost is just slightly more, about $3,000 to $4,000. And then there is virtually no risk of multiple birth because we only put back 1 embryo, for example. Okay. The last indication for IVM is to collect eggs or produce embryos for freezing for fertility preservation. This is particularly pertinent to women who have a cancer or some other medical condition requiring eggs to be frozen, but the type of cancer they have makes it unwise to be giving fertility drugs to stimulate the ovaries. For example, estrogen receptor positive breast cancer. So again, let me just define here. In the conventional IVF, at the bottom, we give them stimulation protocols, either conventional FSH or HMG, using the antagonist or agonist protocols. And we collect many eggs, typically more than 8 eggs. On the other hand, at the other end of the spectrum is the classical natural cycle IVF, where no medications are given. We monitor the patient, and when the biggest follicle is about 17 or 18 millimeters in diameter, we give them an injection of ACG as trigger, and then we collect that 1 egg. But because only 1 egg is collected, the pregnancy rate is like a 10 or 15%. And there's also a 30% chance that the woman may lose her egg before the egg collection is done. So the more common way is modified natural cycle IVF done in the usual way. In this method, no drugs are given until the biggest follicle is about 14 millimeters in diameter. From that point onwards, an antagonist like cetrotide or orgalutron is given every day, as well as an FSH or HMG small dose every day, until the biggest follicle is 17 or 18 millimeters in diameter. This reduces the risk of any early ovulation and losing of the egg, but the likelihood is still to get a single egg. So because of that, since there's only a single egg being collected, the pregnancy rate is 10, 15, 20% that we can get. Mild IVF is obviously a variation of regular IVF, except the smaller dose of medications are given, okay? Where you aim to get 2 to 7 eggs, okay? Now, what I'm about to describe to you in today's lecture is early stimulation, early trigger, modified natural cycle IVF, IVM, in which we give to the patient a small dose of FSH on the 4th, 6th, and 8th day of the menstrual cycle. And as soon as the biggest follicle reaches about 12 to 14 millimeters in diameter, we do egg collection. And we have found that we can get anywhere from 1, 5, or 10 eggs, okay? And at the extreme end, as much as 125 eggs, some of which are mature, most are immature. But then using our modern IVM methods, we can mature most of these immature eggs and get good embryos. And this was a world record of 125 eggs that was set by one of my colleagues, Dr. Michael Dahan, and was published a couple of years ago. So the amount of medications given is the same as for classical modified natural cycle IVF. The number of ultrasound scans and blood tests are the same, except that instead of getting 1 egg, we can get many more eggs. So therein lies the advantage of the method. So again, to summarize, natural cycle IVF without any drugs at all runs a 30% chance of a premature LH surge or ovulation and a 10% pregnancy rate. In the early trigger natural cycle IVF, IVM, if the patient has an irregular period, we induce the withdrawal bleeding by giving them a course of Provera. And then we give a small dose of medication until the biggest follicle is 14 mm, which is different from the classical modified natural cycle, which I described to you just now, where we start the medication only at 14 mm and we get only 1 egg. In over 10 years of using this method and treating more than 1,000 women, okay, we have never had a single patient with OHSS using this early trigger modified natural cycle IVM method. The advantage of this IVM method compared to regular IVF is that it's a simpler treatment and it reduces the cost. Because in most countries, cost of medication is quite high, and sometimes, like in Canada, the cost of medication can be the same as the cost of IVF itself. So in Canada, for example, an IVF treatment cycle could be $5,000 US, but the cost of medication in poor responders can be as high as $5,000 US as well. And it avoids the side effects of medication, which includes gaining weight, bloating, breast tenderness, nausea, mood swings, and in extreme cases, OHSS. Now, this is obviously not in most women, but obviously in the proportion of women. So this is an example, for example, of how this is done in actual practice. We had a 25-year-old lady who had been treated in other centers and developed severe OHSS, and who we noted had polycystic ovaries on ultrasound scan. So we gave her a very tiny dose of Purigon, which is the FSH, okay? When the 2 biggest follicles were 12 millimeters in diameter, we gave her an injection of buserelin, which is a GnRH agonist, with a very, very tiny dose of ACG. And we were able to collect from her 10 mature and 17 immature eggs. Of these 17 immature eggs, 13 of them matured after 1 day, so that we had a total of 23 mature eggs, of which 20 fertilized by the sperm. We transferred only a single embryo, grade 2 embryo, there was 4 cells, and with the baby born, and we were able to freeze for her 4 other day 5 good quality embryos that were at the blastocyst stage in order to help her have 3 or 4 more babies at the later stage. So you can see here a very tiny dose of 3 days of injection of hormones, and we were able to get enough embryos to produce 1 baby and potentially 4 other babies. So this is a picture of a polycystic ovary showing the classical picture described by Professor Howard Jacobs in the 1980s of an enlarged ovary with these tiny follicles in the ovary, described as a string of pearl appearance, okay, and which were quantified at the Rotterdam conference for the Rotterdam criteria of polycystic ovaries, where if an ovary is seen with more than 10 to 12 follicles in any one diameter, is considered the polycystic ovaries. Caroline, can you play the video, please? Caroline? Okay. So because many of you would not have seen an ultrasound egg collection for IVM, I've included a short video clip here. So as you can see here, this is the ovary, and these are the very tiny follicles in the ovary. Notice here that there's a very large blood vessel in this area here. So the method of doing egg collection with IVM is the same as with the IVF, except that we have to be a bit more careful and make sure you have a good ultrasound machine. That's all, okay? So a high quality ultrasound machine, you push the needle to the vagina in the ovary, and you suck out the eggs from each of these tiny follicles, okay? And the procedure itself takes anywhere from 10 minutes to 40 minutes, depending on how many eggs you collect. Whether we're collecting just 3 or 4 eggs, or whether we're collecting 120 eggs, for example, okay? So as you can see here, okay? Fine. So you may wonder, how does an IVF collection differ from an IVM collection? So this was a paper published by one of my former fellows, Dr. Aisha Sehan, who is now a senior doctor back in Turkey. If you compare IVM to IVF, okay, the results are about the same. The length of time to perform the egg collections is about the same. The degree of discomfort is about the same. And the risk of any pain, bleeding, infection is the same between the 2 categories of patients, okay? And this is the paper that Dr. Dahan published, okay, setting a world record of collecting 125 eggs in a single egg collection for a patient who was young with IVM. So the eggs that are collected, if they're not mature, is shown here on the top left-hand corner of a geminal vesicle oocyte. After 24 to 48 hours, the egg becomes mature, and this is the metaphase 2 oocyte. And then we inject a sperm into the egg by ICSI, just like regular IVF ICSI. And then the fertilized egg then grows to the 2 cells, 4 cells, 8 cells, 16 cells, morula and blastocyst stage. The stages of the development of the embryo are identical to that of a regular IVF. So we collect the immature eggs, and then we mature them in laboratory that we had pioneered at McGill University, and which were patented there, and which are now sold by either Cooper Surgical in the United States or by Medical in Europe. And within this media, we add 75 international units of FSH and LH and observe those eggs for 24 to 48 hours, and we check them every 12 hours. Now, herein lies the importance of a skillful embryologist who has to be very meticulous to check those eggs all the time, so that as soon as those eggs are mature, the eggs are fertilized. I remember that when we started OriginElle here, I had an embryologist, Hai Ying Chen, okay, who was very careful observing these eggs, okay, and he would stay at night in the clinic until 10 p.m., 11 p.m., midnight to inject those eggs as soon as they mature. And luckily, our chief embryologist now, Dr. Murid, is of the same caliber. He will stay and even sleep at night. I've seen him checking embryos until 2 a.m. at night, okay, in order that every precious egg is given the best chance of producing a baby. All these eggs which are mature, as soon as they're mature, they have to be fertilized. Because if you wait too long, then the eggs becomes over mature or in simple terms, okay, if you are trying to cook an egg, if the egg becomes overcooked, it doesn't taste well anymore. So the same way, if the eggs are over matured, they don't fertilize well anymore and they don't produce good quality embryos. So it's very important to fertilize the egg, okay, within a few hours of the eggs being collected and become mature. So to make it more easier for patients, okay, and for the embryologists not to work day and throughout the whole night, okay, we try to time the egg collection for the IVM in the afternoon, so that when they are mature, it'll be mature early the next morning, in time for the waking day for them to fertilize the egg. Now, how does one prepare the lining of the womb? Unlike IVF, where the woman's estrogen levels are very high because you are giving them hormones to stimulate ovaries, in IVM, you're not giving the woman much medication to stimulate the ovaries. So the estrogen level has to be added as well. And we give them estrase, which is a preparation of estrogen by mouth or by vaginal pessaries, 1 tablet 3 times a day by mouth, or if it's not enough, 1 tablet 3 times a day by mouth and 1 tablet 3 times a day by vaginal insertion. So the dose of medication depends on how thick the lining of the womb is, okay? And we give it starting on the day of the egg collection, and we start the progesterone after the injection of the sperm into the egg has been done, after ICSI has been done, okay? And the progesterone can either be given vaginally or by intramuscular route. It doesn't matter which way. So as you can see here, we published our landmark paper in 1999, okay, of 25 cycles of women who had average age of 35 years, who had an average of 10 eggs collected. Most of they were immature. We matured 84% of these eggs, fertilized 87% of them. 95% of those eggs continued to divide, and at that time in the late 90s, there was no limitation as the number of embryos to transfer. And because this was a research protocol at the time, we transferred 3 embryos, and we had 10 of those 25 women going off to for babies. So Dr. Chen, Richard Chen, who's now working in China, published his first paper in the New England Journal of Medicine, reporting a 40% live birth rate with these 25 women with IVM. Over the next 10 years, we continued maintaining the results of this IVM. In fact, we improved somewhat, so that by 2009, and we stopped our analysis in 2009 because in 2010, in the province of Quebec where I live, okay, it became illegal to be transferring more than 1 embryo in younger women. So you can't compare results when you transfer only 1 embryo to results when you transfer more than 1 embryo, okay? So we stopped our analysis in 2009. As you can see here, our success rate had increased from the 40%. Now it had increased to about 56% per cycle or per egg collection. And the implantation rate per embryo is 20 to 23% for each embryo. Now you may wonder, are babies born after IVM healthy or not? So because of this, another one of my fellows at that time, Dr. Bucket, reviewed the files of 432 babies born, all in one hospital. 55 of them were born after IVM, 217 were born after IVF, 160 of them were born after ICSI, with 1,300 age-matched spontaneous pregnancies, all of whom were delivered in one hospital. Now, this is a particularly important study because they were all done in one hospital. Because the classification of abnormal babies may vary slightly from country to country, depending on what one considered to be a minor abnormality. Because there's no confusion for major abnormalities, okay? But when minor abnormalities are concerned, some countries consider to be an abnormality, other countries consider to be part of a normal variation. So as you can see here, for the subject we discussed today, poor responders. So here, Dr. Gulekli, who was working with me many 20 years ago, who is now a professor in Turkey, compared 8 women who did IVF and 8 women who did IVM, all of whom had failed IVF several times before because of poor responsiveness, okay? In the IVF group, they were given big doses of medication. Okay, in the IVM group, they were given no medication. Despite that, the IVM and IVF group produced the same number of eggs at the end. Okay, and they had a total of an average of the same number of embryos transferred. And in fact, in the IVF group, none of them became pregnant. In the IVM group, one of them became pregnant. Okay, so here we are not trying to suggest that IVM is better than IVF. What you're trying to suggest is that if egg donation is not feasible, because obviously no method of treatment is going to be as good as egg donation for women in this condition. However, for a variety of reasons, religious, personal, whatever, some women are not prepared or are not able to undergo egg donation. And for those women, IVM avoids the use of big doses of medication. So ask yourself, why would one take such huge doses of medication that may cause side effects and cost a lot of money, when at the end, if you take no medication at all, the same number of embryos are the result. Similarly, another paper published by another group of people at McGill University compared the antagonist protocol, the GnRH antagonist protocol for IVF with IVM, okay, in patients who had failed previous IVF cycles. You can see again, the number of eggs that were obtained, there was no significant difference. The percentage of good quality embryos, there's no significant difference. And in fact, again, in this small series of patients, the IVM results were as good. In fact, they were better, well, at least as good as those with the IVF patients. And the study I referred to by Dr. Bucket showed that the risk of giving birth to an abnormal baby, if you compare IVM, IVF, and ICSI to spontaneous pregnancies in healthy women, was the same. The relative risk for IVM was 1.19, IVF was 1.01, and ICSI was 1.41. Now remember that IVM, we always do ICSI. So it is interesting, in fact, that the relative risk of IVM, in fact, is lower than ICSI. And this suggests to us two things, okay? That in fact, the reason why there's a reported higher incidence of genetic abnormalities with ICSI in some centers or some countries is probably because ICSI is used in those cases for men with very, very poor sperm, where nature never intended them to be a father. But because ICSI was done to bypass the normal fertilization process, okay, the genetic problems that the father had may be carried over to the child. But if you do ICSI, we're using normal sperm, like we do in IVM, there's no increased risk of the ICSI at all, by the procedure itself as per se. And we also compared the obstetric outcome of 1,400 babies born with IVM with those of normal pregnancies, okay? Singletons, twins, triplets, or quadruplets, okay? You can see here, incidence of genetic abnormalities is the same, 2%. Like in spontaneous pregnancies in healthy women, because the normal percentage of abnormal babies in general population is 2 or 3%. And IVM remains the same. In this analysis of 1,400 IVM babies. Now, interestingly, in the last few years, a number of studies have suggested that IVM results, while may not be as good as IVF if you do a fresh transfer, it is as good as IVF if you do a frozen transfer. So these are studies produced from Western Australia, from Walls et al. At Perth, okay, showing that if you look at IVM compared to IVF, okay, if you take a fresh transfer of a single embryo transfer with IVM or IVF with fresh embryos, the live birth rate is much lower with IVM than with IVF. But if you were to do a frozen embryo transfer, the live birth rate for the two groups was the same. So showing that it may not be the eggs themselves that are less advantageous with IVM compared to IVF, but it may be well that the preparation of the lining of the womb, as manifested by a fresh cycle, may be more difficult to do in IVM than in IVF. So that's why it should be done in a frozen cycle. And this goes along the trend today, where more and more centers in more and more countries are discovering that transferring frozen embryos may in fact give better success rates than transferring fresh embryos, even in regular IVF. The key thing, however, is that the maternal and child complications were the same between the two. And the risk of OHSS in IVM was 0 in IVM compared to 7% in IVF. What is also interesting is that if you wonder, is this IVM procedure extremely difficult to learn? Is it only 1 or 2 places that can do it? Well, not really, because a couple of years ago, I had a very innovative, enterprising young doctor from Turkey coming to train with me in Montreal. He trained with me here just for a few weeks, went back to Turkey to set up a brand new center. And as you can see here, he was able to get in women who were young, okay, in their early 30s, okay, early 20s, okay, early to mid 20s, okay. He was able to get, okay, an implantation rate per embryo of 47% with a single embryo transfer, a live birth rate per cycle of 45%, okay, and a live birth rate of 35%. So clearly showing that this IVM technique is something that if a center wishes to do it properly, they could learn to do it properly and get good results. So in conclusion, the injection of HCG to trigger increases the number of mature eggs and the rate of maturation. IVM may be useful in women who have unexplained poor quality embryos or who are repeatedly poor responders to ovarian stimulation and who decline egg donation. IVM in these cases can produce as high as a 35 to 50% pregnancy rate per cycle in young women, and the obstetric and the birth outcome of these babies born after IVM or IVF is the same. In conclusion, IVM fresh embryo transfer rate may not be as good as for IVF, but if you freeze the embryos, okay, and then transfer them, whether it's an IVM embryo or IVF embryo, the pregnancy rate is the same. Although some 20 years ago, we started IVM primarily in response to women who had high risk of ovarian hyperestrogen syndrome, today the indications are moving away from doing that. So the indications of the treatment have changed, but the method of treatment itself with IVM remains important, okay? And this early stimulation IVF IVM method may be a first-line approach in a number of patients and can get good results even in new centers. But I think most important of all is that IVM engenders the importance a center places on every egg. Because in many centers, it is only the best quality mature eggs which are important. The less good quality eggs are basically discarded. Whereas those who adopt an attitude for IVM believe that every human egg is precious, and we should give a chance as best as we can for both the doctors, the nurses, and embryologists working together as a team to give everyone in the world the best chance they have from every stimulation cycle and every treatment cycle. Thank you very much. Thank you, Caroline. I finished.
And wonderful and amazing. Thank you so much indeed for that interesting presentation. So lots of studies you have shown that, and lots of useful information indeed. So huge thanks for presenting this topic indeed. And well, my question to you, first one is, are you ready for the questions from our patients?
Yes, of course. Thank you very much.
Excellent. Thank you so much indeed. And let's have a look at the very first question that we have, which is a bit of a longer question, okay? Let's have a look at it. So my surrogate was found to have a functional cyst when my doctor checked her when she visited the clinic on the beginning of her cycle, so she could not be given the deferelin shot to start the process. The doctor said she gave her some medication and check her again to see if it was gone, so she can do the deferelin at the beginning of her next period. Is this something I should be worried about?
Well, this looks as if it's a different area from what we're discussing today about IVM. However, I think this is something that I don't think you should be very worried about, okay? This can happen to some patients, okay? And because we are talking about preparing the surrogate for embryo transfer. This is what we're talking about, okay? Sometimes some women, especially if they're young, do produce functional cysts, okay? And these functional cysts may stay there for a month or 2 months or 3 months but they invariably go away themselves. Okay, so I think here is where patience is of the virtue, because the surrogate is obviously young. Okay, I will just wait for the surrogate to have the cyst disappear before starting the cycle. In the meantime, freeze the embryos for the transfer in preparation for the surrogate. That's all.
All right. Again, thank you so much for the very first question, and thank you so much for your advice on that as well. All right, and let's have a look at the next question. So, could someone with AMH level at 0.44 get a successful pregnancy with IVM?
In fact, this is a good question. This is exactly the category of patients that we are talking about today. Because here you're talking about a potential poor responder with a low FSH level, low AMH level, okay? So I would say that in most places, we would try IVF in the first instance, okay? Because that's what they're most used to. And in OriginElle here in Montreal and Ottawa, we've had healthy babies born with IVF, even if the AMH level is lower than that level. Having said this, okay, if we get a poor response with IVF, okay, then in the case we would use IVM, and yes, we've had healthy babies born with IVM in these cases. This is particularly because these patients are the ones who are particularly likely to be poor responders.
All right, excellent. Thank you so much indeed for that. And well, best of luck, of course, to our patients as well. Okay, next question is like two parts of the question. So let me go with the first part. I'm 41, my AMH is 0.2, FSH 32, and I have very irregular periods. In recent blood tests, the doctor said my AMH is undetectable. Can I take the HEA or what can I do? And another part is I am a poor responder, had only 3 follicle respond to stimulation during the last cycle.
Well, I will need to know a bit more detail about the actual cycle, okay? But in principle, as I said, an FSH of 32 and an AMH of 0.2 obviously puts the woman in ovarian failure. And the irregular periods is probably because of the ovarian failure. Now, if the doctor wishes to do IVF, you will try IVF first, okay? However, if you try IVF, okay, and you find that there are virtually no eggs, these are the type of patients that we are the topic of today's lecture that we could try IVM in, okay? Now, if the patient were to live in North America, what we will do is have the patient come to Montreal or Ottawa for about 2 weeks and do everything here. On the other hand, if the patient, let's say, lives in Europe, we could work together the center in Europe, do a telephone consultation with the patient, give them our protocol. They could do all the blood work and the essential tests in the Europe, okay? Have the first 1 or 2 ultrasound scans done there, and we might give them a small dose of Purigon or Gonal F on day 4, day 6, day 8, as I showed you in Dr. Dahan's slide, okay? And then after that, as soon as the biggest follicle is 8, 10 millimeters, make plans to come to Montreal or Ottawa. And then after that, as soon as the biggest follicle is 12 to 14 mm, we trigger and we collect the eggs. So the length of time they'll have to spend in Canada will be about a week to 10 days if they're doing a fresh transfer. Or we freeze the embryo, they fly back to Europe, and then they come back at a subsequent time to do the transfer. Okay. Nowadays, flying from Europe to Canada is pretty easy, except for the pandemic, obviously, which has changed all our lives. Okay, but normally there are daily flights or twice daily flights from London, England, from Paris, from Rome, from Spain, from all the major capitals in Europe. So coming to Montreal or Toronto is very easy. And from Montreal, for example, is a 1.5 hour or 2 hour drive to Ottawa. Or we can fly directly to Ottawa as well, stop over in Montreal, stop over in Toronto for an hour, because it's only an hour's flight then to Ottawa. That is for poor responders, okay? The 3 follicles is fine, because obviously that is with IVF, right? So, or is an antral follicle count? I didn't get that part of the question. Was the 3 follicles that the patient was referring to an antral follicle count of 3, or they're talking about 3 follicles after stimulation for IVF?
All right, again, thank you so much for that thorough answer to this particular question as well. And please let us, sorry, I just see that someone was not able to hear, but I just hope that everyone else is able to hear everything, okay? Please let me know. I was able to hear, of course, everything clearly. So Thanks for that. Okay. And in the meantime, let's have a look at the next question. So it's a short one. What is the cost of IVM?
Well, if you exclude the cost of drugs, okay, an IVM cycle, we're talking about $4,000 to $5,000. Okay, drugs would then depends on where you buy the drugs, right? Obviously, you need a bit of drugs, okay. The drugs of but I would suggest buying the drugs in Europe, okay, because the cost of drugs in Europe are a fraction of the cost of drugs in North America, okay. So drugs in North America for IVM might add an extra $1,000 to $2,000, okay, but in Europe it might cost a couple of $100.
All right, understood perfectly. Once again, thanks a lot for that explanation. Okay, next question is up right here as well. Can you recommend us IVM clinics where there were doctors who were trained, like the one you mentioned in Turkey?
I think it'll be probably best if this particular patient sends me an email as to which country she's staying in, okay, she's living in, okay, and I could then suggest perhaps suitable places she could go to near her home territory, okay, because it's too wide to be naming clinics all over the world, even for her.
Okay, no problem, of course. And remember, you can also get in touch with Dr. Tan using the link I have just sent to you. There is a button where you can get in touch with the whole team as well. And I'm sure they will be able to help you out with that question as well. All right. Thank you so much. And let's have a look at the next question. So, I have recently experienced a failed ICSI cycle after 11 fertilized eggs. Unfortunately, none were of good quality after day 3. And were not viable for transfer by day 6. A donation was recommended for me now. Would IVM be an option for me?
Well, IVM would be an option. Whether it would be the best option for the next cycle, I can't know. So in these cases, I would think it's probably best if the patient contacts us directly, sends us a copy of her medical file. Let us examine the medical file in detail first before giving some advice, okay? Because the information is just too general, right? Because obviously 11 fertilized eggs, okay? And then to get poor quality embryos in one cycle itself is not an absolute indication for IVM, but IVM would be an option, I would say, okay? It will depend on her age, other factors, the DNA fragmentation, the husband, whether there are any other factors that are important to consider first, whether PGTA is considered or can be done in that country and so on.
Excellent. Thank you so much for this one as well. And let me go straight to the question again from Kathy. Can egg quality be improved with DHEA and CoQ10 alone? Is there anything else I can do to improve egg quality if IVM isn't an option?
Well, there are many different uh, ancillary treatments, okay, which can so-called improve egg quality. Okay, DHEA, CoQ10 are widely known. There's myoinositol that can be tried. There's maca from South America that can be tried. Some people have tried baby aspirin and so on, okay? But none of these methods are guaranteed to work, okay? We ourselves do give, in some cases, okay, growth hormone in the terms of omnitrope to improve egg quality as well. But this is a method that they should probably discuss with their own doctor, okay? Because I would never like to give patient advice that overruling the patient's own doctor, you know?
Of course, understandable. Thank you so much indeed for that question once again, and of course for your help with that. Okay, next question again, short one. Is there any age limit for IVM?
There's the age limit for IVM is the same age limit for IVF, okay? Means i.e., some centers or doctors will stop doing IVF in women who are 41, 42, 43, and then they will not do it for IVM as well. For us here, the law in Quebec says that for a woman's own eggs, you cannot treat them if they're more than 46 years old. Okay? So obviously for IVM, the same as for IVF, we have to stop at 46. But in Ontario, there's no absolute age limit, okay? So long as the patient has a chance and she understands that the chance is small, the treatment can be done in Ottawa.
All right, that makes perfect sense as well. Thank you so much indeed for yet another question and, of course, your answer. Okay, let's have a look at the next question. I had a failed IVF in July of this year with AMH of 0.44. I am 39 and I would like to try again early of 2021. I am in South America.
And what is the question? Is the question asking me whether IVM is suitable, or is the question asking me what should be done for the next IVF?
I believe so, because actually we are missing the next part. Okay, sorry.
Okay.
But let us know, okay, if that's what you mean. I believe so. If not,
So,
then
so,
just
if the question is whether IVM can be tried, yes, IVM can be tried. Okay, and they can be monitored in South America and come here for the few days, like in Europe. Okay, because like I referred to Europe, because we do receive patients. Okay, and as far away as from Australia, or from Africa, or from parts of Asia, and so on. Okay, so South America is not that big a deal once the flights are allowed. Okay, after the pandemic is over.
all right, of course. Thank you so much indeed as well. And let's have a look. Okay, there's one more question. We will be slowly finishing, but of course, if you have any questions left, you can go ahead and type those in, and I'm sure Dr. Tan will be happy to answer them for you. Okay, and let's have a look at the question. So, what is your opinion about duostims? Is it similar method to IVM?
It's not the same. Duostim is a method of stimulation for IVF. And in duostim, what they do is that they will stimulate the ovaries, okay, by the antagonist protocol, collect all the eggs above about 10 or 12 millimeters in diameter, and about 2 days later, after the egg collection, start stimulation again, and then do a second egg collection. In fact, we have in our center even done the triple stim. That means egg collection, stim, egg collection, stim again. And we do get some successes rarely, okay? However, the cost of medication is extremely expensive because you're talking about 2 or 3 rounds of egg collections, okay, in one cycle, with the cost of the stimulation methods at all. It's quite different from IVM, where we are trying to give little medications and collecting the eggs when they are immature to be collected, okay? So I would say duostim is not similar to IVM.
All right, thank you so much for the clarification. And at least at this point, we do not have any more questions, so I guess we will be slowly finishing. However, before we finish, I just want to mention that if you would like, again, if you would like to get in touch with Dr. Tan and get some more details, I'm sure they will be, he and of course his team will be happy to answer any of those. So you can use the link I have just sent to you as well. And yeah, I guess we will be finishing. But before I let you go, Dr. Tan, anything you would like to add before we finish?
Advances in our field continue all the time, okay? So I'm sure when it's IVF, IVM, advances continue all the time, like in all science, right? But today, clearly, for many of these indications, the best treatment, if the patient is agreeable to it, will be egg donation. There's no doubt in my mind, okay? However, it is only because of personal and religious reasons that egg donation is not acceptable. Okay, and egg donation centers can be obtained in many parts of the world. Okay, and here in Canada, we have a very good egg donation program where we can get vitrified donor eggs from all countries around the world. Okay, and they are tested by United States and Canadian criteria for use in North America. And most importantly is that we do have a connection to get donor eggs from ethnic backgrounds which are very difficult to obtain generally. For example, Han Chinese, for example. Okay, so this is something I will just mention in mind as all as a passing note.
Wonderful. Thank you so much. And in the meantime, one more question has shown right here. So I guess we can still answer this one and we will finish. So have you ever had an IVF specialist from the Caribbean trained with you?
I've had a number of patients of doctors from South America trained with me. Okay, whether they actually came from the Caribbean itself, I didn't go to that detail because I think the Caribbean is a very wide area.
Of course, that's understandable, but thank you so much indeed for that. And as I mentioned, we will be finishing for tonight. So I would like to thank every single one of you for coming here tonight, for asking your questions. I do believe it has been helpful. Dr. Tan, huge thanks as well for your time and for providing all those answers. And of course, your wonderful presentation. As you can see, there are some thank yous coming up your way from all the patients as well. And someone is typing, so let's give it a sec. Yeah, there is another comment for you. Many thanks. Interesting presentation. So Thank you so much. And I just want to mention that, of course, as always, it has been recorded. So, of course, if you unfortunately wasn't able to hear something, you will be able to re-watch this. It will be uploaded on our website, My IVF Answers, and of course on our YouTube channel. And as I've mentioned, this is our final event this year, actually. So, thank you so much, everyone, for joining us over and over again. As I've mentioned, it's been a great run of those events, and we had plenty of those. But I just want to say that, of course, we will be back with some more next year. So stay tuned, and I'm sure you will be able to see that we will be back very very soon. But also, if you would like to get some more details, you can always get in touch with all of our top fertility experts, or simply go to our website. There are some webinars out there as well. And well, thank you so much. And Dr. Tan and everyone, have a lovely day or evening, but also Merry Christmas and a Happy New Year. I do hope that the next year will be a little bit more normal. We can wait for that. So thanks a lot, everyone. Dr. Tan, it has been a pleasure, and I do hope next year we will have more events as well coming up with you.
Thank you very much, Caroline.
Thank you so much. Take care. Bye.
Very close.